Hi and welcome. My name is Michael Boney, and over the next short while I'll be discussing with you just some information about the Achilles region pain, and particularly looking at tendinopathy and how to sort of deal with this in the Achilles region. Clinically, I've come across this condition quite often, and in the past it's definitely been a very challenging condition to sometimes manage. And certainly taking the approach of exercise has helped manage this better in the last few years than it has in the past. Anyways, what I'd like to do is just spend the next half hour or so just talking about the difference between the tendinosis and tendinitis in this region, and just looking at what the misconceptions have been in the past and perhaps what the evidence is showing now. So when we look at this area, oftentimes the typical client who I've tended to see in the past, and perhaps maybe you've experienced as well, is a runner coming in. And runner who is typically a marathon runner or distance runner would come in with posterior heel pain, Achilles region pain, typically sort of mid-portion of the Achilles region, and they're training for a marathon or what have you, and certainly this is limiting their training ability. So when we look at some of the literature, actually looks at runners and comparing that to sedentary controls. And in this article here, printed in the Clinical Journal of Sports Medicine in 2005, they reported that there was a 15 times greater risk for Achilles rupture in a runner as compared to a sedentary control, and a 30 times greater risk of tendinopathy in a runner as compared to sedentary control, which kind of makes sense because if you think about it, they're using that tendon quite a bit more, and perhaps as they age, there may be some breakdown of that tendon. So Karim Khan looked at some of the common misconceptions about tendinopathies and their management, and here we have listed, let's say, the misconceptions. If you look at it, tendinopathies, one of the misconceptions is tendinopathies are self-limiting conditions that take only a few weeks to resolve, where in fact they are often very difficult to treatment, and they may take several months to resolve. Another misconception is that imaging appearance can predict prognosis, and really all imaging does is it adds to the likelihood of diagnosis of tendinopathy. It doesn't necessarily prove it per se, but just gives us a better idea that yes, this is a tendinopathy issue or breakdown of the tendon. But it doesn't really give us an idea as to when this is going to get better. So is imaging always necessary? Well, it's a question that clinically you could ask yourself, depending on what the clinical presentation is with your client. Another misconception is that cyst-like ultrasound abnormalities that are found in tendons are oftentimes an indication for surgery. And really, when you think about it, surgery should be based on clinical grounds. Obviously, an example of need for surgery would be performing your Thompson test, and if you find a positive test, then obviously that indicates more of an Achilles rupture, which would indicate the need for surgery. But we have seen these cyst-like findings in asymptomatic athletes as well, so do they really need surgery? And also that surgery provides rapid relief of symptoms in almost all subjects. Well, if you think about it, and I'm sure that you've experienced clients who've been post-surgical, it takes a while, particularly with Achilles tendinopathy or Achilles rupture and post-surgical repair of that. It can take up to 6 months, and not all patients do well. I've certainly had my share of clients who've had chronic thickening of the tendon afterwards with pain that's associated with it that lasts longer than that 6-month period. So surgery is definitely not always the answer to this. So it brings up the age-old question of tendinitis versus tendinosis. One of the things that we are finding with the so-called tendinitis that we've often referred to in the past, and certainly I have, is the inflammatory cells are really absent. And when they looked at surgical specimens with apparent chronic tendinitis, they weren't finding inflammatory cells. So what does this say? It indicates that it may not necessarily be an inflammatory problem. And it lends more credibility to the possibility that it's more of a mechanical disruption of the collagen fibers, or perhaps a biochemical irritation that results from the damaged tendon that's activating some of the local nociceptive nerve endings. So again, tendinitis versus tendinosis, obviously, with the latest literature, we're starting to understand that it's more of a breakdown of the tendon than an actual inflammatory response of the tendon itself. Now, the pain from this so-called Achilles tendinopathy, or tendinosis pain, there's an implication that the pain is mediated by a neurogenic inflammation response. And it's not the true inflammatory process that you would think about in the traditional sense. It's more in response to the collagen tissue injury that does occur. So what we're finding is that there's no prostaglandin release, which is typically what most of your nonsteroidals, anti-inflammatories would target, or even over your over-the-counter anti-inflammatories would target. But there's more speculation that the pain is in the local nerve fibers, and it's due to the release of peptides that start this pathophysiological painful process. So this is where the neurogenic component comes in. Perhaps the nociceptive nerve endings are releasing mediators that will start a pathophysiology to the pain. And this is more the speculation as to where the pain is coming from, rather than the truest sense of inflammation and having the bradykinin and prostaglandins and those inflammatory mediators causing pain. When we look at the diagnosis of tendinosis compared to the diagnosis with tendinitis, you can see that there's certain characteristics or traits with tendinosis versus with tendinitis. In terms of prevalence, with tendinosis, it's definitely more of a common problem than the tendinitis. In the past, I think we were mislabeling the condition, and we thought that the tendinitis was to be more common than the tendinosis. But we're now realizing that it's really a problem of tendinosis and not true tendinitis. So the time for recovery with tendinosis is about a 6 to 10 week recovery, if not longer. And if it's just a true inflammation of the tissue, it should resolve within days to 2 weeks. The time for full recovery is certainly into the 6-month stage, 3 to 6 month stage, and for the tendinitis is 4 to 6 weeks. The likelihood of full recovery and returning to sport, for that matter, from chronic symptoms, in tendinosis, it's still a fairly good prognosis, greater than or approximately 80%. In tendinitis, it should go away. I mean, with the use of anti-inflammatories and modalities that target inflammation, that should get better most of the time, if not all the time. So the focus for therapy then for the tendinosis should be therapies that encourage collagen synthesis and maturation of tissue and strengthening of the tissue. If you think about the modalities that you might be using in clinic or the methods of exercise that you might be using in clinic, what things will promote collagen synthesis repair? And I'm sure you can think of a couple that would come to mind. Obviously, eccentric training or strength training could be one. From an exercise point of view, is certainly from a modality point of view, you could argue that some of the mechanical effects of ultrasound may be a factor as well. Whereas tendinitis, you're looking at anti-inflammatories. So in terms of classifying these overuse tendon conditions, when we look at tendinosis, the concept here is that there's a degeneration component happening within the tendon. And why it's happening is typically due to trauma that's more on a micro level. Perhaps aging is a factor that contributes to this, and perhaps some vascular compromise. So in the histology of this type of condition, we find that there's collagen disorientation, there's disorganization and fiber separation that is contributed by an increase in ground substance. There's an increased prominence of cells and vascular spaces with or without neovascularization and focal necrosis or calcification. So you're going to get potentially some thickening of the tendon and some nodules within the tendon or calcification that happens. So there's definite physical changes and degradation that happens to the tendon with a tendinosis. And this would explain some of the nodules we'll see and the thickening we'll see clinically. Versus your tendinitis or your partial ruptures, there's symptomatic degeneration of the tendon with some compromise of the blood vessels or vasculature, and there's this attempt for an inflammatory repair response. There definitely can be some degenerative changes noted as well with the tear factor and superimposed with a tear, and you might be getting some proliferation of tissue as well, with some bleeding within it and organization of the granular tissue. But you certainly don't see as much of the degradation of the collagen tissue with this type of condition. So if you look at a theoretical model of tendinosis and sort of the cycle of how this happens over time is, let's say the runner, for example, as our case here, who's got an increase in demand for the tendon, for example, increasing their training mileage. With that comes the potential for, micro tears occurring within the tendon, and certainly there may be this vulnerability to injury that will then have an inadequate repair component to it. With this inadequate repair component, there may be a decrease in collagen and matrix production because it's not going through its fibroblastic phase well enough, perhaps, or maturation phase. That leads to tissue cell death, particularly the tenocyte cells, and then further decrease in collagen and matrix production, which then increases the risk again for injury. You have that athlete who perhaps takes some time off, pain sort of decreases a little bit, but then they go back to their demands of their sport, such as running, and the tendon's not strong enough. It's actually vulnerable to keep up with the demands. So that leads to this cycle of further degradation over time. If there's adequate repair, if there's adequate rest from the sport or from the activity, then certainly the tendon can repair itself and problem can be resolved. I can think of a typical case that I've had in the past who's a marathon runner who's come in to me complaining of the chronic Achilles pain and mid-portion Achilles pain, and constantly, trying to manage the pain, giving her the advice of taking time off of her running and her training, but, being the marathon runner that she is and having to run 3 or 4 marathons a year, she simply did not take the rest that she needed, and the pain continued throughout the course of her running. So, certainly an education factor is definitely important from a management perspective, and letting them know what it could lead to, because the more it breaks down, certainly the concern is obviously Achilles rupture over time. So the causes to Achilles pain, you got to think of other conditions other than tendinopathy, but certainly the most common ones are your mid-portion Achilles tendinopathy. Your other consideration should be the posterior impingement syndrome, and this could happen because of an os trigonon, which is essentially the extra little bone formation that can form within that subtalar joint, the posterior subtalar joint, or the talus, particularly at the talocrural area as well. I have a ballet dancer right now where this is a common condition in ballet dancers who, she's a teenage ballet dancer who is having bilateral posterior heel pain. and we found that it was due to ostrigonin. And we've tried conservative management with her, and simply not making a difference. And it's just from the repeated point position that she has to be in, the repeated plantar flexion position, that is constantly irritating the posterior structures. And so she is a surgical candidate at this point in time to try to manage this. The other consideration for Achilles pain is insertional Achilles tendinopathy. So, you have to consider that right where the tendon inserts into the calcaneus, there is a possibility of retrocalcaneal bursitis, or the possibility of Haglund's disease as another one. And of course, with that, if you think about the adolescent population, you got to consider Sever's lesion as well in that growth spurt stage, where they could come to you with some pain posteriorly as well. So the less common conditions that you're going to find in this region are the Achilles bursitis, the accessory soleus muscle, referred pain from neural structures, perhaps some of the tibial nerve structures, and or the lumbar spine for that matter. So those are things that you have to consider as well. What you want to make sure you don't miss is the Achilles rupture, of course. That's generally an easy one to catch, though, clinically. The partial ruptures are harder to catch, but complete ruptures are easier to catch. Tendinopathies, because of inflammatory arthropathies, are another consideration as well. Your Reiter's condition, your ankylosing spondylitis condition, those kinds of arthropathies are definite conditions that you want to consider as being possible causes as well to the pain in the posterior Achilles region. So just think about that, as those are other possibilities, and make sure that you don't miss those. When we look at the Achilles region in terms of pain, we can sort of break it up into different areas. The musculotendinous junction, the mid portion of the tendon, the insertional portion of the tendon, and then the calcaneus. Pain in the mid portion tends to respond better to treatment than pain at the insertion, and this is as reported by Karim Khan. Bursa, are sources of pain. There's no question, and you have to consider that. And again, the superior lateral tubercle of the calcaneum, if it's enlarged, this is what we call Haglund's deformity, which could lead to that symptomology of Haglund's disease. So again, sort of considerations as to where you're going to have your client presenting with pain. Certainly the mid-portion one tends to be the most common from an Achilles tendinopathy point of view, and that's what more often than not you're going to be treating. So here's an histology picture just showing you what the tendon would look like as it breaks down in the mid-portion of the Achilles tendon. You can see the top part, the tenocytes are aligned, and that would be a normal alignment. In the mid-portion, you can start to see the tenocyte disarray that happens within the collagen fibers, and then adding to that hypervascularity component. So typically, a degenerative lesion with partial tears is about 20% of the cases. So you're going to see this degradation of tissue with some partial tears within that. Of course, the collagen fibers in disarray, and that's really what the tendinosis component is. It's the breakdown of collagen fiber, the disorientation of collagen fiber, which then leads to hypervascularity in an attempt to repair itself, but the tissues don't really repair. There's no signs of tissue repair that occurs, and we also see no signs of inflammatory cells, so it's not an inflammatory problem. So your classic mid-Achilles tendinopathy clinical features. Oftentimes it's a gradual insidious onset. They're going to often complain of morning pain and stiffness, and that pain and stiffness improves as the day goes on, or improves with activity or with heat. After an activity or after they've been on their feet for a little while, the pain tends to recur several hours after the activity. And you notice this thickening or this sort of crepitation sensation that they'll either report or you'll experience. Oftentimes there's a nodule present, and typically unilateral calf tightness. Again, some of the biomechanical components can lead to biomechanical errors can lead to ankle or subtalar joint stiffness. I have a 50-plus-year-old lady right now that I'm treating for this very condition, and she was visiting Europe for a while and did a lot of walking in Europe outside of her norm. Came back and started noticing this gradual onset of pain that got worse in the morning, better as the day progressed, and certainly has the classic nodule and thickening of the tendon, with the Achilles tightness and calf tightness, and with subtalar joint sort of stiffness as well. And so, it certainly fits a picture clinically. So what increases the risk for this condition? Well, there's always a consideration of genetics in terms of collagen content and collagen strength. But most of the times it's going to be tendon overload, and that could be from many different factors. It could be from years of running, from increase in activity, whether it's distance, speed, or gradient, so any change in that. Decrease in recovery time, so not giving your body the rest time that it needs. Change in surface or footwear, excessive pronation, which tends to overstrain the tendon, calf weakness or poor flexibility of the calf muscle, and again, restricted range of motion, particularly with dorsiflexion. So those are factors that will lead to that. So biomechanically, when you're doing your biomechanical exam, these are things that you want to be looking for. Looking at the subtalar joint, looking at the talocrural joint, looking at the calf musculature in terms of strength and flexibility, and then questioning about their activities and change in activities in that. So just a quick chat about treatment with mid-Achilles tendinopathy. MRI was still always the gold standard in terms of showing the collagen loss as the main problem. So the MRI is good in the sense that it gives us an indication that, there's collagen tissue disruption. But again, so what? I mean, obviously you want to find out if there's a rupture there or not. But in terms of prognosis, it just doesn't give us a whole lot of information. So the collagen production is the key cellular phenomenon determining the recovery from the tendinosis. So, our ability to promote collagen synthesis is what's going to really end up helping the client in the end. So what things can we do to help promote collagen synthesis is what we should be targeting from a treatment perspective. Yes, there's going to be adjunctive therapies that you're going to look at addressing as well, and that could be, your training errors that you might consider looking at, equipment faults or equipment that the person might be wearing, obviously shoes being a big factor, and then looking at their biomechanics. How is their biomechanics of their whole lower extremity, their hip in terms of movement, their knee, their foot and ankle, lumbar spine, and is there any issues that we need to address further up the chain or what have you? And along with that goes the muscle imbalance factors as well. In terms of other treatments, in terms of modality-based treatments, what's been reported out there, ice, obviously, to help reduce the hypervascularity component. Bracing, that being more like your heel lifts and your teeping strategies to unload the tendon, essentially, and allow it to repair itself. And then some reports of electrotherapy has been a consideration as well in terms of helping laser, high-voltage galvanic stim. Perhaps you can throw in there ultrasound. And, that's basically to help, again, with that tissue repair concept. Okay. One of the things also to consider, and that's gained a lot more popularity in the past decade, is mechanotherapy, and that being more the eccentric training drills to increase the tendon strength. Really what we're looking at doing here is stimulating tenocytes to produce collagen tissue, thereby reversing that tendinosis cycle and hoping to create more of a normal alignment of the tenocytes. And that's what I'm going to spend just a bit more time on discussing in the next slide or two. Also consideration is there's been systematic reviews done. The Cochrane database has systematic reviews that have looked at corticosteroid injections, and the basic conclusion from that is that there is short-term pain relief only. From a long-term perspective, it tends to come back. From a short-term perspective, there is some relief that people will experience. Why that is, I'm sure you can speculate as to the many reasons as to why that might be. One of the things that I think about, though, is that long-term, if you're not addressing the tendon problem, the tendon breakdown, then certainly you're not going to address the root cause of the problem, and the problem will come back. And that's maybe why you've seen people go for cortisone injections in the past, and good for a couple of months, and then it comes back. Certainly other considerations are the other types of injectable therapies that are out there nowadays, sclerosis and PRP, plasma-rich protein injections as well. And so there's definitely more information that's surfacing on those types of therapies as well. Let's go back, though, to this mechanotherapy concept. And Karim Khan talks about mechanotransduction, and that's the term that he's labeled this as being. And basically all this is saying is that you're using exercise to promote tissue repair. And specifically, by definition, he thinks of mechanotransduction as being the process of where cells convert mechanical stimuli into biochemical responses to repair tissue, and that tissue is tendon, muscle, cartilage, and bone for that matter. I mean, we've certainly seen it in bone. How do you heal a fractured bone? Well, you start stimulating it by weight bearing on it. And what is that? It's a mechanical stimulus. And what does it do? It starts this biochemical process or response to build osteoblasts and promote new bone formation, basically. And obviously bone healing starts with a soft callus, and that's basically collagen tissue that starts to be laid down. And as more weight bearing occurs, obviously there's that collagen tissue that turns into more bone tissue for that matter. So there's this three-step process that Karim Khan talks about, and the first being this mechanocoupling process or component where you need a mechanical trigger. The mechanical trigger obviously is some form of exercise. The second process is then once you have this mechanical trigger, you have this communication that occurs between cells. So cell-to-cell communication, basically what this does is it just distributes that loading message. You've introduced load. That load has to be converted into a message that's distributed from one cell to the next. And then that causes what's called an effector response, which is where this cells will respond in order to repair the tissue itself. So we are basically converting mechanical stimulus into a cell tissue repair process. And it was an interesting write-up on this by Karim Khan and Scott, and that's published in the British Journal of Sports Medicine in 2009. Based on that concept, then, this eccentric program makes sense. And this is a program, a 12-week program that's been in the literature since the late 90s, actually, and it's been revised over time in terms of how to do this. But Alfredson and colleagues have reported, who's one of the original developers of this 12-week heel drop program, reported to have a 90% success rate. And that success rate included adjunctive therapies, and what they talked about as being the adjunctive therapies is looking at the biomechanical factors and the biomechanical errors, looking at the flexibility and addressing tissue flexibility as well, perhaps through some massage, or looking at the stiffness in the subtalar joint, talocrural joint, and addressing those mechanically as well. But what this protocol involves, and perhaps you may have done this with some of your clients. If you haven't, this is something that you may want to may be worthwhile considering. Looking at, and it's fairly aggressive. It's more aggressive than I realized. Looking at it as having 180 drops per day, so that would mean just lowering the heel 180 times in a day. And the way it was broken up was 3 times 15 reps twice a day. 7 days a week for 12 weeks. So that's pretty aggressive in terms, and you definitely need a high level of commitment from your clients in terms of them agreeing to do this. But basically, it would be two exercises, one being a gastroc drop, so obviously knee straight, and one being a soleus drop with the knee flexed to 45 degrees. And you're only focusing on the eccentric component, where the method of doing the exercise would be to go up, raise back onto the toes using the other leg or the arms for that matter. So you're not loading the tendon concentrically, but you're only loading the affected tendon eccentrically. So you're helping yourself with the other leg or your arms to go up, and then you are removing your other leg off, so you're only weight bearing on your affected limb, and then slowly dropping down so that you can add that eccentric component. And you would progress this until they were pain-free. And you would add, over time, over the 12-week process, you would add load progressively. So they would add weights into their hands or load onto their spine or whatever the case is. And the other component was that it would be done through pain. So if there was pain reported, they would continue to progress through that pain. So that would be something that you may want to consider trying with some of your clients. And with the one client that I mentioned to you guys about who's in the 50-plus years of range, who went to Europe and essentially developed mid-Achilles tendinopathy, I instituted this program with her, and we are about 8 or 9 weeks into it at this point in time. And she's definitely improving. She's talking about having less pain. She's talking about being able to walk longer distances without pain. And certainly what I've noticed over the last 8 or 9 weeks is that there's a gradual decline in the thickening of the tissue. And this is just, of course, my clinical observation and anecdotal. However, it's something that I've noticed definitely work more just recently. All right, so let's look at the insertional Achilles tendinopathy shortly here, just to really bring your attention to this area. You know, this is more a condition of the enthesis, and it's, you know, essentially where the tendon blends in with the calcaneus. And there's different considerations when you are looking at this area. If somebody presents to you with insertional Achilles pain or tendinopathy, you have to be considering the possibility of a rheumatoid arthritis condition or another spondyloarthropathy. So like an AS condition, ankylosing spondylitis. So just keep that in the back of your minds. If they're talking about pain over their calcaneus, literally, then those are considerations. So you would look for other signs and symptoms, of course. Obviously, you got to think about retrocalcaneus bursitis, Haglund's disease, which is intimately related in pathogenesis, so the two of them can kind of go hand in hand. And if you look at the diagram there, you'll notice that the Haglund's deformity happens basically at the superior aspect of the calcaneus. With this, you'll see that there are physical changes in the tissue through mechanical load. Again, this mechano transduction sort of concept kicks in. And so this enthesis organ is where you are going to get a lot of this pain occurring. And the enthesis organ basically includes the bursa and the Achilles insertion into the calcaneus or calcaneal region. Okay? In this case, you can certainly get true inflammation of the calcaneal bursa, and that's something to consider as well. So they apparently tend not to do as well from a clinical perspective, so just sort of be aware of that, and certainly something to consider when you're treating them. The other consideration in terms of tendinosis is the tibialis posterior tendon. If you look at the diagram of the tibialis posterior tendon, it basically dives underneath the whole midfoot and sort of supports the whole midfoot. So it's efficient to stabilize the midfoot. It certainly depends on its physical condition and innervation and the pulley system. However, it's designed to support the midfoot. The muscle develops maximal tension at its normal length, and if you start overstretching this, greater than 110% of its length, it starts to become broken down. It reaches its adaptive potential, and it's exhausting that, and that's where the tendon breakdown occurs. So the collagen bonds will start to be strained at that 3 to 4% of elongation, and so what you start to see is more microscopic damage occurring. Again, this tendinosis component to that. So when you have failure of the pulley system, and this could be perhaps from excessive pronation through the subtalar region or midfoot region, that can start to cause excessive lengthening of the tendon, and therefore the breakdown. Or if it starts to, if you start to get slippage out of the groove behind the medial malleolus, that can lead to a breakdown of the tendon. Obviously, trauma, separating the tendon from its insertion points, whether it's in the navicular or sustentaculum tali, those are considerations as well. Instability of the tuberosity of the navicular, as an example, would be an avulsion fracture. Obviously, this would be in your adolescent population or pre-adolescent population. And then restriction of dorsiflexion could cause some of the breakdown as well with this. So those are some considerations. All right, so that just concludes the short discussion on Achilles region pain and looking at tendinosis versus tendinitis. So I'm hoping that basically what you walk away from with this talk is that we are going to consider the Achilles region more from an exercise perspective as therapists. It's something we can definitely promote, and we have some good literature that helps to back us up with that exercise component. And perhaps an education factor is huge in terms of letting people know that the Advil may not always work to help them cure their problem. It may help reduce their pain perhaps, but there again it may not be completely effective if it's not an inflammatory problem to begin with. So I want to thank you for listening. Again, my name is Michael Boney, and have a good day.